10. A 40-year-old man with a skin-colored skin nodule. That was a little redundant, I guess a typo. Skin-colored nodule on the flank. Now, Arnaud is here, and I was a little nervous since this is something that he basically is the world expert about. So I was like, oh, I got to study extra to make sure I don't say anything that's too wrong. And again, I told you, skin-colored nodule, right? So many things look like a skin-colored nodule. It doesn't matter what these cells are. They're going to look like a cyst or a lump, okay? The nodule is a circumscribed nodule down in the dermis. And that's a very interesting pattern when you go closer. It's made of spindle cells that are plump, geflus, right? Geflus is one of my favorite French words. I was giving a lecture in Quebec in Canada, and they were saying geflus, geflus. I was like, what is that? And they're like chubby. And I was like, oh, plump is the word that I use in English, but I like geflus. It sounds much more beautiful to my ear. So geflus. The cells that are spindled, but kind of have round to oval nuclei and more cytoplasm, right? Kind of a grayish cytoplasm, maybe a bit pale. And they have this very unique pattern where they're kind of like that spindled or desmoplastic melanoma we saw earlier, where you have the packets, kind of the cells are running in somewhat little short fascicles maybe, to small clusters or packets with collagen in between. Some of them have kind of prominent central nucleoli, many of them do, and many have, in this case, have pale nuclear chromatin. So by immunohistochemistry, these cells were positive for SOX10, S100, and patchy MART1, or melan-A. To me, maybe Arnaud can clarify, but I think of MART1 and melan-A as more or less the same thing. I think there may be a clone difference. So what do you do with a lesion like this that is staining melanocytic, has these cells that are, have prominent nucleoli, has this unique pattern of spindle cells in these little short nests or fascicles with collagen in between, is a circumscribed nodule, so that's not usual for many nevi, right? To have this like perfectly rounded nodule. One thing I would think about is clear cell sarcoma of soft tissue, which can sometimes present in the dermis or subcutis. But it's not quite right for that, but it does bear some resemblance. And this is a very unusual entity. This is, I think, the only example that I have seen of this, although I suspect there may be others out there, but the only one that I've recognized. And this is, I will pull up the paper to show you here. So this has been called several different names, but I think the current name that is being used by some authors at least is cutaneous melanocytic tumor with CRTC1 TRIM11 fusion. And at some point also melanocytoma with CRTC1 TRIM11 fusion has been suggested. I think it's an interesting tumor to know about. So far, very few cases have been reported, although I think that will change in the future. There are more, I'm sure, that will be published. But a couple things that it makes me think of, it reminds me a little bit of clear cell sarcoma. It also reminds me a little bit of epithelioid schwannoma. So epithelioid schwannomas are a relatively rare subtype of schwannoma that have more plump epithelioid cells, and they have this kind of clustered, packeted kind of arrangement. Instead of Verrier bodies, the cells kind of curve together and make almost little nests that are surrounded by collagen. So I remember when I saw this case, this has now been published in the literature by my former colleague Sarah Shalin as part of this paper here. And so when I first saw it, she showed it to me, and I said, well, it kind of reminds me of epithelioid schwannoma maybe. And then also there's a tumor that was described long ago by my mentor Sharon Weiss as a paraganglioma-like dermal melanocytic tumor. Now, I have never seen a true paraganglioma in the skin, to my knowledge. I see them in soft tissue, but I have not seen one in the skin. So these tumors were described by them because of that kind of Zellballen, right, or nested appearance as being a paraganglioma-like. And probably in retrospect, this tumor that they described probably falls under this category. I don't think those cases have been historically tested, although that would be cool to get those original cases from an archive and test them. So and then to rule out clear cell sarcoma, you can do FISH for EWSR1, the Ewing's gene, which is rearranged in essentially all cases of clear cell sarcoma. And the thought about these tumors is that they should have a good prognosis, very indolent, although there has been one case that has been discovered after it metastasized to the lung, and in retrospect with testing, it showed this same fusion. So it kind of called into question, is it potentially possible that these tumors could be a variant translocation, be actually clear cell sarcoma with a variant translocation? I don't know that I personally buy that idea, just because this tumor does look different to me than classic clear cell sarcoma. But it does at least raise the question of, will some of these with long-term follow-up show more aggressive behavior? And as clear cell sarcomas, you often have to follow them for many years to see how they behave, because they are not always rapidly aggressive. They are kind of aggressive, but over many years sometimes. So I think this is one of when Agnes invited me to do this, she said classic difficult cases and also new evolving entities. So this is one of the new entities recently described, something I only learned about in the past few years and still have only limited experience and knowledge about. So you can read some papers in here. One thing that I thought was interesting is that in some of the cases described, the tumors were diffusely positive for SOX10, but were negative or focal S100 or negative for other melanocytic markers. I'm curious to hear from Arnaud is that common? Because this case had S100, but is it common that they're S100 negative or weak?
It can be variable.
Variable.
For all the different patterns and types of...
So SOX10 is the best marker. Okay, so for those at home, Dr. de la Foucharier said that the markers can be variable. SOX10 seems to be the best one. And earlier you mentioned that they usually are NTRK positive?
It can be NTRK positive.
Okay, so pan-TRK, the marker for NTRK, NTRK, that marker is often positive in these tumors, or sometimes maybe. So I hope to see more of these in the future and more papers on this topic.
I made a video of one.
Oh, they're on Arnaud's, on your YouTube channel?
Yes.
Yeah, so Arnaud de la Foucharier has a really awesome YouTube channel about complicated and unusual melanocytic lesions. So you can check that out and look. And if you have trouble finding it, if you look on my YouTube, I have a playlist called Other Pathology YouTube Channels. And as I find more pathology YouTube channels, I try to add them to that list so people can find them more easily. Because that's my goal, is that eventually there will be YouTube videos for all the different specialties freely available for the whole world. That would be amazing. Because people all the time say, oh, can you make a video about brain tumors or liver biopsies? And I'm like, no, I cannot. I only do skin and sarcoma. So I'm in no way qualified to talk about how to grade liver fibrosis and inflammation. Nope. But there are people out there who need to know those things. So I love finding more pathologists who are actively teaching online. And I'm really happy that I learn a lot from Arnaud, because he has experience with melanocytic tumors that I rarely or never see in my practice. And so I'm teaching you not as an expert in melanocytic lesions, but as someone who's in the trenches with you, fighting the war, trying to figure out every day, is this melanoma or not? Is the patient, do they need an excision? I don't know. So this is how I approach these cases. So you can read here. I've left some literature, which I believe are most, if not all, of the current publications on this topic. So you can do some more reading. And I should have left your video a link in there, I guess. I will have to find it and tweet it. That's what I do. All right.
And what is the complementary treatment for this type of tumor? Is there a re-excision, or it depends on the case? Or
no one knows.
There is no...
The question from Agnes is, what's the proper treatment for these? And I think with many rare things, you don't know. I personally would think probably negative margins is a good idea, right? Yeah. I mean, that's kind of the approach for any uncertain malignant potential, or I think even newly described lesions where we think it's probably indolent, but there are so few cases we don't know. Yeah. I think if it were on me or my wife or my daughters, which is kind of the gold standard I use, I think I would want a negative margin.
Because on this specimen, the margin are negative, but with 1 or 2 millimeter. But is it sufficient or?
I can't remember.
Not enough, I think.
That's
I can't remember. I can go back to the paper, but I want to say that this was re-excised, I believe.
Yes. Yes.
So,
Of course.
and I have seen a case since this one that I thought was either clear cell sarcoma or this, and we did testing for both, and it ended up being clear cell sarcoma. So there are similarities there, and probably some of the lesions that have been described as primary dermal melanoma, a nodule of melanoma in the dermis, which is a controversial idea, but probably some of those may fall under this category. Just in the past, people did not know about this fusion. So obviously, this is the new thing in pathology, right? More and more, I think we will find tumors that are defined by, or in some ways defined by their fusions. But I don't think it will totally take away the need for morphology, because as we've seen, molecular pathology answers some questions beautifully. But then it creates new ones, where you have tumors that are totally different and yet have the same fusion. And they stain differently and behave differently. A good example would be clear cell sarcoma and angiomatoid fibrous histiocytoma. Completely different tumors, yet they can have the same fusion. How? I don't know. I don't understand it. Yes, Arnaud?
Also, there are some clinical relationship, because sometimes the patient, they complain about pain or tingling in the tumor, which is, I don't know any other melanocytic tumors that have some functional symptoms.
So Arnaud was saying that sometimes this entity has been reported as having neural kind of pain or tingling, neuropathic type symptoms, but that's an unusual thing compared to most other melanocytic lesions would not have that presentation. So that maybe there's something unique about this. That's really fascinating. Thank you so much. The next one is a 20-year-old woman with a skin-colored wrist nodule, present for several years, and it's attached to the tendon sheath on imaging studies. No history of malignancy. So 20, a young patient. Now, that's a perfect section, right? I mean, a couple folds and a little scratch here. So it happens if you don't protect your unstained slides, little bits get scratched off. But overall, it's a perfect example here. So right down here, this dense band of pink, let's look at that before we look at the tumor. See how wavy that is? Wavy is not usually nerve. Everyone teaches nerve, wavy. Nerves are like gentle waves, maybe, slow and gentle. But when it's like this, ramen noodles or instant noodles, the little package of dry noodles that you take out when you're in college and you're poor and you can't eat. I don't know, at least in America we have them. I don't know, maybe not in France. You have them? What do you call, comment tu dis? Noodle. They're wavy, right? Really wavy when they're dried. And then you add the hot water, and then they get soft. So one of my fellows, Dr. Ed Fulton, really awesome fellow of mine in the past, trainee in dermatopathology, he said, it looks like ramen noodles in the package, how wavy. When it's that wavy, it's usually not nerve. It's usually collagen, dense, regular connective tissue. And that type of tissue encompasses tendon, ligament, fascia, and a lot of things that are fibroblastic lesions that have a background of collagen. What happens is during processing, the tissue shrinks up. And in the fibers that are normally stretched out, they become very, very wavy. So the only reason I belabor this point is that I have encountered not just trainees, but practicing pathologists many times that have struggled to identify that this is not nerve. This is fascia or tendon sheath, dense, regular connective tissue. It can make a very big difference. For the example here, the reason we need to know is that we know that this tumor is down deep enough that it's sitting on the tendon sheath or the fascia and directly adherent to it, attached to the collagen of the tendon sheath. Now, basic histology is always so important. Even now, all the time, one little tiny finding of histology sometimes will make a difference between recognizing that something's not a little bit of melanoma in a lymph node. So I really think you can never spend enough time learning all the subtleties of basic morphology for normal histologic structures. So here, this tumor is a nodule, kind of multinodular. It's very pale from low power. And as we go closer, you can see a lot of the cells truly have clear cytoplasm. All right? In other areas, the cytoplasm is not truly clear, but kind of pale, like here. Kind of pale gray or pale eosinophilic. So it can run a range as far as how clear the cytoplasm is. I think the most classic areas are down here, where the cells are arranged in, again, these kind of nest/fascicle overlap. Okay. They're these, if you cut them longitudinally, they look like long fascicles of plump spindle cells, geflus, right? Oh, sorry. If you cut them in cross-section, they look more like nests. So it is a matter of three-dimensionally if it's cut long or across. The cells are relatively uniform. Their nuclei are oval and all look like each other, okay? That is a general feature of most translocation-associated neoplasms, particularly in soft tissue pathology. If there is a balanced rearrangement or a gene fusion, usually the tumor will have nuclei that all look alike because they all have the same molecular event that's driving the tumor. Pleomorphism oftentimes is a marker of underlying chromosomal instability or aneuploidy, random chromosomal gains and losses. This is not a perfect rule, but it works pretty well because if you think about all of the translocation sarcomas, synovial sarcoma, Ewing sarcoma, clear cell sarcoma, which is what we have here, and more. They may have mitoses or necrosis, but you don't see pleomorphism usually. Now this tumor, when it recurs or metastasizes, can sometimes get pleomorphic, but usually it does not. And it's a really great rule, solitary fibrous tumor, translocation associated. It's a really great pearl that one of my mentors, Dr. Mark Edgar, taught to me. And he taught me a lot of really great visual tricks and tips in soft tissue pathology that I now pass on to everyone whenever I speak. So the cells are uniform. They do tend to have prominent nucleoli. See the nucleolus there? I'll show you a better area in a minute. There. Nice nucleolus, almost that cherry red nucleolus, like the nucleolus of a melanoma, a little bit. The other thing is that in between the nests there is dense collagen, dense pink collagen, dividing these nests or fascicles like this, okay? So these features are characteristically seen in clear cell sarcoma, which has also been called in the past, much to the confusion of many, melanoma of soft parts. We now know these are not melanoma in the traditional sense. They are separate and distinct. And this was first described, or at least the landmark paper describing them was by, I kind of think as my academic grand-père, Franz Enzinger. He trained Sharon Weiss. Sharon Weiss trained me, so he's like my grandfather. He would probably not, I never met him, unfortunately. He died before I was a pathologist, but he, not only this, but he described many of the main entities in soft tissue pathology. Really an amazing legend, and it's really great to be able to see these tumors that he characterized in the 1970s and 80s with no molecular or anything, just morphology. Those days, wow, amazing. So that pattern right there is what should make you think of clear cell sarcoma. So a few things. One other thing that's, let me see if I can find it. I should. There's another feature you often find in clear cell sarcoma. Oh, look at the nucleoli there. Very big. And look, the nuclei look round, not oval, because again, it depends if you cut them long or cut them across. The nuclei look different, whether they're elongated or round, right? So, oh, sorry, I don't know why these keep, okay. So that is a good, and then in here, there should be a multinucleated giant cell. I thought I had it. It's right. I've looked at this slide enough times. I should have it memorized, but I get lost. Oh, come on. 2 seconds.
We have time.
We have time. Okay, good, good. It is embarrassing. I should have. Oh, maybe I did take a picture. Hold on. Ah, that is not a two-tone cell. That is not a histiocyte. It is a tumor giant cell. The nuclei here look the same as all the other nuclei. They are just fused together to make a ring-shaped, kind of halo-like multinucleated giant cell. It's a common feature in clear cell sarcoma. So these tumors, the reason the name melanoma of soft parts or of soft tissue came about is that they do have some similar cytology as melanoma, the big nucleoli. They have a very similar immunophenotype. They stain with S100 and SOX10 and MART1 and HMB45. And I just learned today from Arnaud that they are positive for NTRK, right? The pan-TRK marker, which is cool, and I didn't know, and I'm going to have to try that out in my lab next time I see one. Oh, whoops. That's not a slide. That's a PowerPoint. Okay. There. So when they have classic morphology like this, great, clear cell sarcoma. You see it, you've done immunostains, it stains like melanoma, and then you recognize by the morphology, this must be clear cell sarcoma, and you do FISH or RT-PCR to show the fusion, which is EWSR1, the Ewing's gene, with ATF1 in most cases, and there's a rare variant fusion also. The problem is that if it doesn't have classic features, if it looks like maybe this, well, then you might struggle. Because when I look at a picture of that, I don't instantly think clear cell sarcoma. I would scratch my head and think of a variety of different things. I mean, there are areas here that vaguely remind me of the CRTC, vaguely. Arnaud's probably shaking his head like, no, surely not. But I mean, I don't know, I might think of melanoma. I mean, it's pretty solid. It's not truly clear. It's kind of gray cytoplasm. Yeah, there are some nucleoli, but they don't instantly give me the classic feeling of a clear cell sarcoma. So one thing I recommend is if you had say you had a nodule of melanoma in the deep dermis or subcutis, if you see a nodule of melanoma down deep, that is metastasis until proven otherwise, right? When we see a nodule that's deep dermis or subcutis, that is the way that metastatic melanoma presents. So if I see something that I think is a nodule of melanoma that looks like maybe it'd be a metastasis and it's on the extremity of a young person who has no history of melanoma, well, is it possible? Yes. Melanoma we see present as metastasis with no known primary. On a regular basis, I've seen that. But in a young person on the extremity, that would be rare, okay? So in those cases, I stop and think, could it be clear cell sarcoma? And if I have any doubt, then I do the molecular, because it probably does make some difference for treatment. Say you want to excise these with negative margins, and if it's a metastatic melanoma, usually they will still excise it, but the margin status is not quite as important because it's already stage 3 or stage 4. The other difference now is that in the age of targeted therapies and checkpoint inhibitor drugs, which are very expensive, at least in the United States, and they're drugs that come with a significant potential side effect profile. The potential maybe to cure or turn metastatic melanoma sometimes into a chronic disease, or maybe even cure it, but at the risk of very severe side effects. And I had a relative actually who unfortunately died from metastatic melanoma and took checkpoint inhibitors and really had a lot of side effects, really bad ones from it. So they're amazing, miraculous drugs, but they also at the same time, when you unhook the immune system and let it go unrestrained, it comes with bad side effects. My understanding is that people have tried checkpoint inhibitors, some with clear cell sarcoma, but I don't know if there's been proven success because these are very rare. I only see these maybe once every 2 years or so. Very, very rare tumors. But I always try to think of them if I'm thinking of a metastatic melanoma, particularly in the extremity of a young person with no history, okay? So it's good to know about. You can test for it with molecular. And unfortunately, the 5-year survival is pretty decent. But if you follow patients 10, 15 years or beyond, the prognosis becomes much, much worse. They tend to recur, metastasize to regional lymph nodes, and eventually have distant metastases, which is very unfortunate. So, and they often affect young people, young adults. So it makes it even more tragic. Terrible disease, but one that's good to know about. And I think this is, to me, a very characteristic example of clear cell sarcoma. Anu, would you have any comments you'd like to add? I would love to hear your viewpoints. This is great. I get to attend the session and be talked.
So,
now I feel bad. I put him on the spot.
So regarding the case that was metastatic, did not have a proven intradermal primary.
Okay.
So one of the hypotheses I put in my initial paper is that maybe like leiomyosarcomas, they could be encased in the dermis, and that will prevent the dissemination to other parts of the body. So
the idea for the CRTC1
yes,
TRIM11?
and I know that also for, this is a deep, soft tissue
Yes.
side, but we know that the skin ones that are rare, they tend to perform less poorly than these deep tendon lesions.
So Dr. de la Foucharière said that one idea going back to the CRTC1 TRIM11 is that maybe they are better because they're small and superficial, and that being intradermal gives a prognostic benefit, right? We know that some diseases that would be bad when they're deep, like leiomyosarcomas, behave much, much better when they're confined to the dermis or superficial soft tissues. That's true of pleomorphic liposarcoma, a very bad tumor in deep soft tissue, approximately 50% 5-year survival. But when it's in the skin or subcutis, the vast majority of patients essentially survive and do fine. So some tumors are much better when superficial. Now that doesn't apply to all rhabdomyosarcomas in the skin, still terrible disease and metastasize and act aggressively. So there are some clear cell sarcomas. This is the classic where they arise off of the tendons or aponeuroses, but some of them present as intradermal, and Arnaud was saying that those have been reported to have better prognosis. So that's really interesting. Thank you. All right.